All right. Hello, everyone. Welcome to the first ever Mainstream Monday virtual morning report. We're trying out this new format of VMRs called Mainstream Monday. Today's the first one. And really, the purpose of these VMRs, the Mainstream Monday VMRs, is to focus on bread and butter medicine. I think sometimes on VMR we see a whole range of cases, but sometimes it gets into the esoteria and the HLH, which we love to learn about. But I think it's also, really important in clinical reasoning to get our reps in on the bread and butter and kind of the common things, the atypical presentations of common things, because that's really what we're going to see the most. So that's really kind of the inspiration behind these Monday VMRs. And importantly, I want to say that while these Monday mainstream VMRs will be only dedicated to kind of common bread and butter cases, bread and butter cases are welcome and even encouraged every single other day on VMR. So just wanted to make sure that was clear to everyone joining. But really excited to co-discuss with Youssef today. Youssef, do you want to add anything to kind of the thinking behind these mainstream VMRs?
Yeah, hi everyone. Really encourage you to sign up on our website to present a case. And this is to emphasize that any case is welcome. And this will be similar to real life, where the majority of your day to day is going to be common disease. And very rarely do you see rare disease. And I think that's going to be really awesome. So I'm really excited for it. Ravi, thank you so much for presenting a case. Did you want to say a word?
Oh no, excited to present one of our morning reports from Sinai. So a case that we usually will see. So absolutely stoked to be able to bring this case to you.
Awesome. And huge shout out to Sana, who's scribing for the very first time, and Sime for doing teaching points. And yeah, these sessions will be a little, I forgot if I said this, but they'll be a little bit shorter than usual. Then it'll be 30 minutes rather than an hour. So I think we can jump right in. Ravi, mic to you.
Okay, great. So today's case is a 88-year-old female. She has a history of dementia, history of PE, rheumatoid arthritis, and she comes in altered mental status, shortness of breath, and diarrhea. And I'll stop there for discussion.
Awesome. Yusuf, do you want me to tackle this one first? Okay. So we have an older woman, history of dementia, pulmonary embolism, and RA, who's coming in with altered mental status, shortness of breath, and diarrhea. I think when you have multiple chief concerns, sometimes it can be really difficult to figure out where we should invest our energy. Because do we want to only think about diarrhea and then kind of incorporate altered mental status and shortness of breath, or vice versa? I think, understanding it can be helpful to choose which one to focus on based on the severity. So just as an example, if someone is baseline alert and oriented times three, no issues in their mental status, and now they're coming in and don't know their name, location, that's a very significant change from baseline. So in that case, I would be focusing on the altered mental status. Or an example in shortness of breath, if someone at baseline doesn't wear any oxygen and now they're maxed out on heated high flow, that would be a very significant change in their oxygen requirement, and then I would focus on that. So I think, to me, understanding the severity of all of these, what is the severity of the change in mental status, what is the severity of the shortness of breath, will allow me to figure out which one to focus on. I think in someone, when you have an older woman with underlying dementia, the term altered mental status, I think their history of dementia becomes quite relevant, because you want to understand what is their baseline mental status, and this new change in mental status, how different is that from their baseline? Maybe I'll pause there, Yusuf, and hear what you have to like incorporate on that, and then where you'd be focusing your energy at this point.
Yeah. And Maddie, I wanted to ask you the question as well, is like altered mental status, shortness of breath, and diarrhea.
Yeah.
Based on your experience, which out of these three do you think we're going to find an etiology?
So yeah, great question. I think probably I'm leaning towards the shortness of breath, because I can see, in an older person who at baseline doesn't have much cognitive reserve, in someone with dementia, in my experience, it doesn't take much to push their mental status a little bit worse. So as an example, we think of kind of the MIST framework for altered mental status: metabolic, infection, structural, toxin, which we can get into. But if someone going into kind of the infection category, if someone has a pneumonia or a skin and soft tissue, or sometimes a urinary tract infection that's kind of ascended, an infection like that can cause someone with baseline low cognitive reserve to have change in mental status on top of that. So that's why I think the shortness of breath is what I would be leaning towards focusing on right now, and that the cause of that might be the explanation for the change in mental status as well.
Yeah, that is what I was thinking as well. Like whenever I heard this presentation, somebody who has dementia is altered. Okay, I wouldn't even have to generate a long differential for that until I can, if there's like altered mental status that's just like delirium, if there's like a focal deficit is one thing, but I would say the vast majority of cases it's just going to be delirium. So I'm not necessarily focusing my energy there, especially initially. Also,
Yeah.
diarrhea is really hard to quantify. Like somebody walks in and tells you I'm having 30 episodes of diarrhea. You're like, okay, I'm probably gonna need to explain this. But in the vast majority of cases, it's just like I am having a little bit of loose stools. And the vast majority of cases, like, okay, do they have like an infection, the flu, that's very commonly presents with diarrhea, COVID, that very commonly presents with diarrhea, all forms of pneumonia. Even though we learned that Legionella causes diarrhea, all forms of pneumonia cause diarrhea, like maybe 30%, like maybe 1 in 3 patients with pneumonia present with diarrhea. So I think, like you're saying, I'm on time point zero. I'm altered mental status. I'm not paying a lot of attention. I'm keeping in the back of my mind, no pun intended. Diarrhea, trying to quantify it, and then the short of breath has my attention. It's like, oh, somebody's delirious, and you found out they're shortness of breath. How did you find that out? That's really
Mhm.
curious. Like, did the patient say something? Are they on oxygen? So, Ravi, can't wait to hear more.
Absolutely wonderful. This is sort of discussion I had during this morning report. So you guys are right on track. So I'm going to give you a big, so since we don't have a lot of time, I'm going to give you a big aliquot. So backstory, she had recent flu infection treated with Tamiflu. She's, however, still having confusion since the flu and drowsiness for the last 3 days, diarrhea for the 2 days, and more shortness of breath over the last day. Review systems, what was elaborated on before. She wasn't able to give much because of the altered mental status. Past medical history, she has history of pulmonary embolism on Xarelto, urinary retention, has a chronic indwelling catheter, rheumatoid arthritis on prednisone, GERD, and history of breast cancer, not on any medications, in remission. No family history. There is smoking history. I'm not able to quantify. And then examination, vital signs. I did send the case to Sana, so she can look off the picture. So blood pressure 103/66, heart rate 92, respiratory rate 22, temperature 37.8, pulse ox 97% on 4 liters nasal cannula. General, she's drowsy, wakes up to touch. And the lung exam, bilateral lower field coarse breath sounds. And then Foley, draining dark urine, skin, no wounds, and neurological exam, non-focal, and stop there for discussion.
Awesome. Thank you, Ravi. And sounds like, to recap, this patient had a recent flu diagnosis and was started on oseltamivir and steroids, or steroids maybe for the rheumatoid arthritis, and they're on a blood thinner. And on vitals, we hear about a high respiratory rate and oxygen requirement, and then generalized, what it sounds like, altered mental status with no focality, some decreased breath sounds, and dark urine. Just to start off with the background, recent flu. And flu is very, very common right now in the US. So where I work, 1 in 4 flu tests that are being sent are coming back positive for the flu. And when my patient called me for oseltamivir 2 weeks ago, I called the pharmacy, and the pharmacy had run out of it. That's how common it is right now. So with that in mind, what are some complications from the flu, and how can we think about that? So you get a flu infection, and then you go to the pharmacy and you get a steroid, or it sounds like they're already on steroids, and that can predispose you to delirium, especially if they got it somewhere, if somebody prescribed it. Very, very common etiology. Is there a pulmonary defect? So did they initially have the flu and now they have a bacterial pneumonia? And how would we know, or how would we diagnose a pneumonia? And a lot of times you think, okay, patients are going to come and tell you that they're short of breath, and you say, okay, this is a pneumonia, but it's actually really, really difficult because we might get an X-ray now and let's say find an infiltrate, but how do we know that this is like a bacteria there that's causing the pneumonia? And oftentimes what ends up happening is that the test of time ends up being really, really important, and the acuity. So let's say this patient is in room air, you're able to tell them, okay, we can just wait. But a lot of times, if they are on oxygen already, you would image them, look for the infiltrate, and see if the infiltrate is antibiotics responsive. And the test of time oftentimes is a good test to tell you in hindsight whether this was an infection or not. And a lot of times we treat before we diagnose in these scenarios. And so here we have like this respiratory rate with like high oxygen requirement of 4 liters, which is presumed to be new. So I'm wondering, was the flu a susceptibility that caused the patient to develop a bacterial pneumonia? So I'm looking for that on the imaging. And Maddy, what complications of the flu do you think of other than bacterial pneumonia?
Yeah, Yusuf, that was fantastic. I think in terms of complications of pneumonia, and so bacterial superinfection is a big one, and kind of to elaborate on that, when we think of kind of the pathogens that cause pneumonia, in the vast majority of cases, most usually you don't have a specific bug that's identified. I think when I was learning about this, I think it's around 60% of cases of pneumonia, you don't isolate strep pneumo or viral infections. You're just treating kind of empirically based off of the clinical syndrome, and then also looking at the kind of the test of time, as Yusuf said. But when you do isolate an organism, most commonly it's viral, but then you can have bacterial pneumonia, and that's like when the most common ones are kind of strep pneumo. But complications, I think of kind of a bacterial superinfection. You can get issues related to source control, where you can develop an empyema and no amount of antibiotics will be sufficient to clear that infection. You need drainage, like a chest tube, for example. And then you can also have complications, just such as kind of like a persistent cough, like a post-viral cough after a pneumonia. Those are the big things I think of. I think practically what I would be looking for next is, we see she's on 4 liters of nasal cannula, clarifying, is she on any baseline oxygen requirement, or is this new for her? And then I would want to get imaging of the chest. So a chest x-ray, but maybe also even a CT scan. And to use this point, imaging is not required for the diagnosis. And in fact, chest x-rays can miss pneumonias. And so if the clinical syndrome is compatible, even with a normal chest x-ray, a chest x-ray can be falsely negative in like up to 30% of cases. So that's just a kind of an asterisk you need to have in your mind when you're looking at the chest x-ray. But I'd be curious about the leukocytosis, starting with the chest x-ray, and then if the patient is not improving, kind of low threshold to get a CT chest to evaluate if there's an empyema or some complication. Any other thoughts, Yusuf?
Yeah, I love that, Maddy. And I think the only thoughts I would add is that the American Thoracic Society released a guideline in 2025, which is now officially last year, where they said that even if a patient has a viral infection and they're admitted for a new like oxygen requirement or worsening illness and they have comorbidities, that you should go ahead and treat them with antibiotics, even if you identify a virus. And the Infectious Disease Society of America did not agree with that endorsement, but I think it all depends on the patient's scenario, and in real life, a lot of times, if they're needing to be hospitalized, like depends on the setting. If they're needing to be hospitalized, you can't afford to wait a few days and then see it. A lot of times, you will end up treating and then see. The other things I can think of is PE, because that's always like an infection can also be a risk for PE, and we saw that a lot with COVID infections. And finally, the last thing I would say is that this also came back from 2025 is we saw how much patients with pneumonia benefit from steroids. So even though in our minds, like, oh, steroids are lowering immunity, so they don't work. In reality, we know this with COVID, right? With high oxygen requirements, steroids lower the inflammation, has a mortality benefit. And we see that with bacterial pneumonias as well. So let's say this patient's oxygen requirement goes up, then you would actually think of giving steroids, which is counterintuitive to like classical teaching, but this is like how will change in the future, especially if the oxygen requirements go up, this patient becomes more sick. So that's where I'm at, Ravi. We try to extract as much juice as we can from the alcohol.
Oh yeah, you guys like extracted liquid from a stone. That's amazing. So let me give you that data that you asked for. So white cell count 14, predominantly neutrophils. Chemistry, sodium 130, potassium 3.0, renal function, everything else was normal. Chest X-ray, right-sided infiltrates, upper lobe, lower lobe infiltrates. Left-sided, I think there was atelectasis, hence some of the crackles, lower lobes. And then urine analysis was done since she had a chronic SP catheter, which was exchanged in the emergency room. So positive leukocyte esterase, many bacteria, many white cell counts, positive nitrites. And I think, yeah, I'll stop there for discussion. Oh, yeah, you asked Maddy about chronic oxygen use. She wasn't on oxygen at home.
Was not on oxygen. Got it. Yeah. Ravi, thank you for such a fantastic case so far. I'm going to take a second to summarize where we are. 88-year-old woman, history like notable for underlying dementia, chronic suprapubic catheter, RA on prednisone. Coming in with shortness of breath and change in mental status in the context of recently being diagnosed and treated for the flu, found to have a new oxygen requirement, coarse breath sounds, a neutrophilic leukocytosis, and an infiltrate on chest X-ray. That, in my mind, is kind of like all the pertinent information. And I think if we think of, making the diagnosis of pneumonia, I would say that this person is kind of meeting that, right? You have, I generally think of it as you have like signs and symptoms that localize to the lungs, signs and symptoms of inflammation that can include kind of fever, leukocytosis. And then ultimately, as Youssef said, kind of the test of time. When you give treatment for pneumonia, do they improve? Do they improve with that? We talked about how, infiltrate on imaging is supportive of the diagnosis as well, but is not, especially on chest X-ray, like required for it because there are certain circumstances where chest X-ray can miss this. So I think what I would be framing this right now as viral pneumonia with superimposed concern for superimposed bacterial component. The reason why I'm thinking that is because of the neutrophilic leukocytosis and then the fact that the symptoms have like gotten worse and not improved with treatment just for the viral infection. So I think to Yusuf's point, I would be treating her for a bacterial component. And I think depending on where you work, the specific agents will be different. Sometimes it can be ceftriaxone and doxycycline. And generally what you're trying to cover, the ceftriaxone is for kind of the quote unquote typical pathogens. Those are things like strep pneumo. And then the ceftriaxone, or in some cases, the azithromycin or doxycycline, depending on where you work, is for kind of more atypical pathogens. Those are things like mycoplasma, for example. So probably what I would be doing is starting with treating her with those two agents, or kind of whatever is the practice pattern at your hospital based on kind of your antibiogram. And then I would kind of monitor her for improvement in her symptoms over the next few days. And that would kind of determine my next steps. If she starts having worsening oxygen requirement, the next step would be kind of a CT scan to assess, as I mentioned, for an empyema or consolidation. But I think at this point, if she's on 4 liters, starting her on treatment with antibiotics and monitoring from there. I think with the UA findings, I would be treating her for like a superimposed bacterial component and not treating the UA findings, because if we're to have kind of a urinary tract infection, they need to have symptoms. And so I haven't heard yet. I haven't heard about dysuria, suprapubic pain, etc. And so I would be, you can have an abnormal UA when you have a kind of a chronic indwelling Foley. So I would not be treating that at this point unless like her clinical course really changes. Youssef, what would you be doing differently? What would you add?
Uh, Great discussion. I think the only thing I would add is that in real life, we're gonna have a phase of uncertainty in the next few days when caring for this patient, and that's normal. So with like lupus, a lot of times, for example, you have a confirmatory test, which is the anti-double-stranded DNA. You just order that test and then you're done. In real life, like somebody just has an infiltrate and new oxygen requirements. Can we say definitively that this is not just aspiration? Like, could if they have got like had a ascending urinary infection, developed UTI, and they're like a little bit altered, and then they developed an aspiration, and that's why they're on oxygen? Maybe, right? And the this is real life medicine where you will probably cover them for a pneumonia, and if you start with ceftriaxone, that's also going to cover most urinary infections, if any. And then the test of time will be very, very helpful here, like you're saying, and waiting for that antibiotics to kick in and seeing if, and then defining your thresholds to do more tests is helpful. Like you can say out loud, like, I don't know what this is right now. It could be aspiration, probably a pneumonia. Could there be a urinary infection? Maybe she's at risk because of the indwelling Foley. My diagnostic threshold is 2 dots. Worsening oxygen requirement, I'm going to get a repeat imaging. No improvement after 5 days, I'll get a better picture, and etc. So even despite the uncertainty, just creating thresholds where you would do further investigations is always helpful to guide trainees as well. So back to you, Ravi.
Absolutely. So I'm going to give you some of the culture results, and then you elaborate on that, and I'll give you the final. Well, the culture results will give you the diagnosis. So blood culture is negative, urine Pseudomonas grew out, and her urine antigen strep pneuma was positive. Urine Legionella antigen was also positive, and I'll stop there for discussion.
Wow. Is it me or you, Maddy?
I think it's you.
Okay. I was hoping it was you. I'm just kidding. No, I think one really helpful thing in infectious disease is to know what organisms you expect to be in certain like flora and what organisms are almost never like part of your flora. And Pseudomonas in the urine in somebody who has an indwelling Foley catheter, not surprising. Like if you get all the patients with indwelling Foleys and you test for it, probably not surprising. Urine strep. So that's positive. So I think that would make me want to think of like this patient has at least some strep bacteria. And one thing I learned recently is that unlike staph gets like develops broad resistance to like common antibiotics, and then you end up having to give vancomycin, for example, etc. My infectious disease colleagues calls strep like dumb. Like staph makes fun of strep because strep doesn't develop resistance. So for the most part, your common antibiotics like ceftriaxone are gonna cover strep in the vast majority of cases. And if you notice, like we never talk about like significant strep resistance, thankfully for now. And then what about the urine Legionella? And I think how does one get Legionella, and does this patient have Legionella? So Legionnaire's disease, Pontiac fever, you develop the organism can be in bodies of water, like cooling units, your AC, and especially if this patient lives in a community, for example, the cooling units in the water can grow this organism, and then you can inhale it, and then you develop like pneumonia-like syndrome. Legionella loves mucous membranes, so it can cause pneumonia, but also can cause diarrhea. That's the classical teaching. Interestingly, it's can also cause damage to muscle, so it can cause like elevated CPK, and then that a small hint can be like an elevated AST to ALT ratio. It's an intracellular organism, so your azithromycin should cover it. And the only thing different that I would do is potentially do contact tracing. Is like seeing, okay, where does this patient reside? Do we have any clue? And for example, I had a patient last year with Legionella, and we ended up just calling the facility, and she resided like in a nursing home. So we were trying to see if there was like a source of water. What are you thinking, Maddie?
No, I completely agree with you. I think the picture is consistent with a previous viral pneumonia superimposed with this bacterial component with Legionella and strep pneumo. We talked about how in the majority of the cases you usually don't identify a pathogen, so this is atypical in that sense. But among the typical organisms, strep pneumo is very common, and so I think I'm not surprised to see this. And I think as you taught us, the diarrhea is can be explained just by like kind of the flu in and of itself, but also consistent with the Legionella finding. So I have nothing else to add to your teaching, but I know we're getting close to the end here. So Ravi, I'm curious if you wanted to kind of share like your experience with the case and anything you wanted to highlight.
Oh no, I think it was a fun case. You absolutely at the beginning. I love you honed in on the oxygen. Which one? We had this similar conversation with my group. Which one is going to get us to the answer quickly? And it was the shortness of breath, and everything else is a bystander. And then going through, the backstory of flu is interesting. As flu infiltrates through the respiratory system, it does cause sort of an immune paralysis of all these safeguard mechanisms in the airway. So that makes it very easy for bacteria then to come in afterwards and then set up shop and cause infection. And I think the labs were pretty much, the chat was also talking about Legionella, the hyponatremia was there, the diarrhea and so on, ultimental status. Although I don't know how much of that and the UTI and just the infections, strep pneumo can also cause that as well. So the symptomatology was paralleling what the patient had, but we were kind of taken aback to having both strep pneumo and Legionella urine antigen positive. That was this kind of blindsided us. I thought this fit Legionella nicely. CPK was normal too. I've seen that before, like Youssef had mentioned, with rhabdomyolysis happening in patients. And so with this patient, the antibiotic regimen, we would have to cover atypicals as Zithromax, and because of Pseudomonas also, another infection, if you think about it. So this patient had like a triple whammy. So they started cefepime and Zithromax, and then like, wait a minute, ultimental status. So they switched it over to another, I forget which anti-pseudomonal antibiotic, plus Zithromax, and the patient returned back to baseline. So absolutely wonderful job with the discussion, and it was a lot of fun. Thank you.
Thank you so much, Ravi. Amazing case.
Yeah, amazing case, Ravi. Thank you so much for bringing this and doing the first case on Mainstream Mondays. All right, we'll pass the mic to Seema for the teaching points.
Thank you so much for the wonderful discussion, and so happy to join the first Mainstream Monday session. And after this wonderful teaching, I'll just share my favorite teaching point, which is that in pneumonia, always infection is present, but maybe it is not detected. So diagnosis is made by the entire clinical picture we have. And it is the test of time, and just seeing how symptoms improve with treatment is something that can help us make progress. And thank you so much, everyone, for joining and for a wonderful session.
Thank you all. Thank you, Seema, and thank you, Sana, for scribing, Ravi for presenting a case, and Youssef, always the best discussing together. Bye, everyone. We'll see you next time.